Now remember that we said that the major difference between nephrotic syndrome and nephritic was the degree of proteinuria. Nephrotic syndrome is defined as being greater than 3.5 grams of protein a day. Did you ever wonder what the maximum productive capacity of your liver for protein each day is? It's 3.5 grams of protein each day. You see, if your kidney urinates out 1 gram, your liver simply makes more. If your kidney urinates out 2 grams, your liver makes more. But when it gets to 3.5 grams of protein a day, your liver cannot make more, and the level inside the bloodstream starts to come down. So when you get hyperproteinuria, you get low protein endemia. And then you get hyperproteinemia, and then you get edemia. So look at what happens here. We get hyperproteinuria. Hyperproteinuria leads to hypoendemia, and then you get edemia. Also known as low oncotic pressure gives you edema. Now let's take a look here at this slide. Hyperproteinuria, 3.5 grams of protein. Which form of nephritic syndrome that we described before, which of the forms of glomerulonephritis can cause nephrotic syndrome? And the answer is any of them can. Any of them can. Now, what is the difference between the edema of nephrotic syndrome and the edema of something like congestive failure? The edema of congestive failure is almost exclusively in dependent areas of the body. What's lower down? My lower extremities. Now, because of the low oncotic pressure, the edema of nephrotic syndrome can be anywhere, including around the eyes. So unless you're walking on your hands, it's not a dependent area. Now, why do you get hyperlipidemia? It's not really clear, but what we think is that lipids are cleared from the bloodstream because of apoproteins on their surface. If the apoproteins have been urinated out, then the body doesn't know they're there. It can't see the lipids. It can't clear them. So they accumulate in the body. They lift up and up and up. Hyperlipidemia. Now, if the amount of protein in your body that was excreted into the urine was constant all day long at 1+ protein on a urinalysis, if it was constant all day long, that would give you about 1 gram per 24 hours. If the amount of protein in a urinalysis of 2+ protein was constant all day long, that would give you 2 grams per 24 hours. But proteinuria is not constant. Proteinuria varies based on the degree of renal function in the daytime. That's why the initial test to diagnose hyperproteinuria has to either be a 24-hour urine or the much more efficient spot protein to creatinine ratio. If you have a protein to creatinine ratio of 3 to 1, you have 3 grams of protein per 24 hours. A protein creatinine ratio of 2 to 1, you have 2 grams per 24 hours. Nephrotic range proteinuria. If you had 3 grams of protein, what do you think you get on a urinalysis? 3+. What if you had 5 grams of protein? What would you get on a urinalysis? 4+. What if you had 10 grams of protein? What would you get in the urinalysis? 4+. What if you had 400 kilograms of protein coming out of your urine? What if what was coming out of your urethra was like Tasty Delight, soft frozen yogurt, so much protein? You would get 4+ protein. Now, why does it only go to 4+? And the answer is that once you're in the nephrotic range of proteinuria, it doesn't matter how nephrotic you are, because once you have above greater than 3.5 grams, you're nephrotic. And once you're nephrotic, it doesn't matter how nephrotic you are. Hyperproteinuria leads to hypoproteinemia, leads to edemia and hyperlipidemia. Remember, congestive failure is dependent edema, pitting edema in dependent areas. pitting edema in dependent areas. But here you see the face has got all this edema because it's the loss of fluids into the extravascular space. And this is what happens with low oncotic pressure. Now, nephrotic syndrome, in addition to all the other nephritic diseases we talked about, happens with any general damage to the glomerulus, most commonly being diabetes and hypertension. Any form of nephritic syndrome can become nephrotic. When you get all that protein going into the urine, the protein in the urine forms little short crosses called Maltese crosses. Basically, the protein in the urinalysis forms fat droplets that look like that. Little fat droplets for the Knights of Malta, the Maltese cross. Now, in addition to losing the proteins, you also lose anticoagulants into the urine, protein C and protein S. So therefore, nephrotic range proteinuria is associated with thrombotic complications and hypercoagulable states, also known as thrombophilia, because I love to thrombose, thrombophilia. Now, although people don't talk about it as much, all the carrier transport proteins for all the metals in the body are also lost. You become iron deficient, copper deficient, and zinc deficiency gives you protein healing problems, skin healing problems. You lose transport proteins. Now, the 24-hour urine is very hard to do. You have to collect it for 2 days, then you send it, it's hard to collect. But a single spot protein-creatinine ratio will correct for the variation in the daytime of how much protein that you are releasing based on how much renal function. So 24-hour urine should be a thing of the past. The protein-creatinine ratio is the thing to do. Now, all of those systemic diseases that we said before can cause you to have nephrotic syndrome. But in addition to them, there are several primary disorders of the kidney that have no systemic manifestations, like nil lesions and membranous glomerulonephritis and focal segmental glomerulonephritis. These do not have systemic manifestations that are characteristic. These do not have blood tests that are characteristic. So the only way to diagnose these, you see, is the renal biopsy. You see, Wegener's granulomatosis, I have a nice blood test, a Cianca. Good pastures, I have a nice blood test, a basement membrane antibody. But nil lesions, membranous, focal segmental, mesangial, membranoproliferative, do not have blood tests. You have edema, proteinuria, hyperlipidemia, Maltese crosses in the urine, but you can't tell which one it is until you do the biopsy. That's why for all of these, the answer is the same. Whether it's membranous, nil lesion, membranoproliferative, the best initial test for all of these is a urinalysis and the protein-creatinine ratio. The most accurate test for all of these is a biopsy. The best initial therapy for all of these is steroids. Now, they either respond a lot, like nil lesion responds a lot, or they respond a little, like focal segmental, but it's always the same. Best initial therapy, steroids. Steroids don't work, add cyclophosphamide or mycophenolate. ACE inhibitors is a therapy for anybody who has proteinuria. It's not specific to these diseases. Now, although we can't make a specific diagnosis without a biopsy, we do know that there are certain associations. We know that nil lesion is most common in children. We know that membranous is most common in adults. We know that focal segmental is associated with HIV and with the use of intravenous drugs such as heroin. But that doesn't prove them, they're just an association. Membranous is the most in adults. Now, in addition to that, cancers like lymphoma and breast cancer can do it. Infections. Remember what I said? The most common cause of death from endocarditis in the pre-antibiotic era was glomerulonephritis, membranous glomerulonephritis. Non-steroidals, for an idiopathic reason, can also cause you to have membranous glomerulonephritis. Hepatitis is an immune-active virus that causes antibodies to accumulate in your kidneys. Nil lesion, although it's the most common in children, you can't tell until you get a biopsy, where the light microscopy looks normal, but electron microscopy shows the abnormality. Why does non-steroidals call nil lesion? I don't know. Neither do you. Membranous glomerulonephritis and membranoproliferative chronic hepatitis, chronic infections of any kind can cause you to have glomerulonephritis. Treat the underlying infection. Why does dipridamol and aspirin work? I don't know. We think that platelet activation is causing part of the problem, so we treat with 2 antiplatelet drugs. Why does that work? Because it does. Now, this is a picture of a photomicrograph, and I'm happy to report to you that you don't have to read photomicrographs on step 2 very much, but that is what the glomerulus looks like. The crescents are visible. This one is for pathology boards. Focal segmental. Although it's associated with heroin and HIV, you can't tell until you get the biopsy. Nil lesion responds a lot to steroids. Focal segmental responds a little to steroids. But the best initial therapy for all of them is steroids. If steroids is ineffective, cyclophosphamide or mycophenolate. Well, nephrotic syndrome. You've really pissed me off, said the protein to the kidney. Isn't it wonderful to take something that used to be so complex and to make it feel small? Nil, membranous, proliferative, focal segmental, mesangial, urinalysis best initial test, protein creatinine spot ratio, more accurate, biopsy the most accurate, best initial therapy, steroids. That doesn't work, cyclophosphamide or mycophenolate. And you're done.